I just run through a short case. It's a case of myocarditis we encountered around 2-3 months ago. This was a 71-year-old female, hypertensive, osteoarthritis, was admitted to some hospital with a history of fever with chills, disorientation, irrelevant talk for a day. She was found to have atrial fibrillation, hypotension, hypoxemia, required invasive mechanical ventilation, Norwegian support, and was shifted to Jupiter for further management. On admission, the patient was afebrile, tachycardic, 140 per minute, hypotensive, required high dose of noradrenaline. Peripheries were cold, clammy skin, urine output was low. Typical features of hypoperfusive state. The saturation was 70% on 100 FiO2 with invasive mechanical ventilation. The endotracheal tube had fluffy secretions. On auscultation, there were bilateral crackles, conducted sounds. ECG showed sinus tachycardia and non-specific STT changes. So, based on this information, it was quite clear that the differential diagnosis would be something related to the heart. And so we thought of certain causes, which included acute coronary syndrome. She's old, hypertensive, likely to have acute coronary syndrome. History of fever, possibly myocarditis, infective endocarditis, possibly a stress cardiomyopathy, or severe ARDS. So this was a time when we used to get a lot of COVID cases. COVID patients also presented with myocarditis. The EBG on admission showed severe metabolic acidosis with high lactates, hypoxemia, and she looked quite sick. This was the X-ray. It showed bilateral infiltrates, totally white out, and possibly secondary to pulmonary edema. This was the echo. It showed severe LV hypokinesia. IVC was congested. The RV also had a depressed function, evident by the decreased TAPSE. TAPSE is tricuspid annulus peak systolic excursion. These were the admission investigations on the 30th of September. They were fairly okay, except a marginally low platelet, borderline creatinine, and marginally elevated SGOT, SGPT. In the next 2 days, the SGOT, SGPT just rocketed to 15,000 and 9,000, and the creatinine was gradually jumping. She was oliguric, requiring a lot of vasopressors. She was initiated on IABP to manage her hemodynamics. In the workup for her illness, we sent her troponin, which was elevated. So she had cardiac injury. NT-proBNP was high. The cultures were negative on admission. Malarial antigen, dengue, NS1 were negative. Flu panel to work up for respiratory pathogens was negative. Lepto IgM was equivocal. However, her Chikungunya PCR came positive. She wasn't someone who was complaining of typical COVID symptoms, but this was an atypical presentation of Chikungunya with myocarditis. In the management, predominantly she had cardiogenic shock with multi-organ failure, which was managed with noradrenaline and intra-aortic balloon pump. The IVP was weaned off by day 4. The urine output gradually improved. The acute kidney injury was probably secondary to ATN because of the cardiogenic shock. The acute kidney injury required 10 to 12 days to start recovering. They required 2 sessions of dialysis at the end of it on day 9 and 11, predominantly because she had developed encephalopathy. So we had a suspicion whether she is having a uremic NKF or whether she had residual sedative medicines on board. Shock level gradually improved as the hemodynamics improved. Thrombocytopenia started improving by day 8. Further course was complicated by encephalopathy, as I told you. On evaluation, when we did the MRI showed bilateral symmetrical parieto-occipital T2 flare hyperintensities, which go with press, which is also a rare complication of chikungunya. Patient was tracheostomized on day 10, gradually weaned off from mechanical ventilation. Encephalopathy gradually improved, and tracheostomy was decannulated by day 22. A follow-up echo performed on day 26 showed a better LV ejection fraction of 45%, and which was global. Patient shifted to ward on day 27 and eventually discharged home on day 31. The final diagnosis was chikungunya fever with myocarditis, with cardiogenic shock, with pulmonary edema, with acute kidney injury, shock liver, thrombocytopenia, and stress. Now, myocarditis is not a very common finding, and commonly it is seen secondary to infectious causes. Common infectious causes include viruses, commonly Coxsackie virus, adenovirus, dengue. In our part of the world, yes, dengue is a common cause of myocarditis. Bacterial are rare. Spirochetal and rickettsial are even rarer. Protozoal and helminthic are also rare causes of myocarditis. Other non-infectious causes, they include cardiotoxins, various drugs. Anthracyclines are common. Secondly, certain hypersensitivity reactions to various drugs or snake bites. Systemic disorders, some connective tissue disorders, thyrotoxicosis, sarcoidosis, even radiation can cause myocarditis. Chikungunya fever, it was first described during an outbreak in southern Tanzania in 1952. In the local language, it means to be contorted, pseudoperis, because of arthralgia. So all this while, the patient never complained of arthralgia. However, when the encephalopathy resolved, the patient started complaining of multiple joint aches. So actually, she might have had polyarthralgia, but she couldn't complain because of the encephalopathy. The first outbreak in India was reported in 1963 in Kolkata. The RNA virus, it belongs to the alpha virus genus of the family, Tobacco, and as you all know, it is spread by Aedes aegypti virus. It inoculates into the subcute. It multiplies in the fibroblasts and is spread to the other organ systems through lymphatics and then the bloodstream. Commonly involved systems are the joints, followed by the heart, brain, liver, and the muscles. Now, fever, myalgias, and polyarthralgia are the commonest symptoms, occurring in more than 90% of the patients. Rash occurs rarely, less commonly. It's like 50% of the patients. Viremia is in the first 5 to 7 days, and the IgM is detectable after 3 to 8 days and is detectable for about 1 to 3 months. For the diagnosis, in the initial phase, it is the PCR, which is RT-PCR of the RNA virus, which is reliable. And in the later phase, it is the IgM which is to be tested, ELISA for the IgM. Now, laboratory, so initially, we might have had chikungunya outbreaks cases which were not monitored or laboratory proven. Still, the government numbers, the suspicious cases are far higher than the actually laboratory proven numbers. Now, what the chart shows only the laboratory proven numbers. The blue are the Indian numbers and orange are the Maharashtra numbers. So progressively you can see that the proportion of Maharashtra numbers is rising. And yes, this year we did see a lot of chikungunya cases. At Jupiter, a total of 306 samples were tested for chikungunya RT-PCR, out of which 160 samples. So more than 50% positivity rate for chikungunya this year. And chikungunya is not a common disease of the IC. However, this year we did have a spurt in cases of chikungunya with atypical presentations. Many were myocarditis, encephalopathy, optic neuritis, and acute inflammatory demyelinating polyneuropathy. Chikungunya myocarditis, it is described in case reports and observational studies. Incidence is up to 5% of the cases. Common clinical features include fever, arthralgia, chest pain, fatigue, palpitations, hypotension, arrhythmias. Diagnosis is presumptive based on symptoms, cardiac enzyme elevation, ECG findings, and echocardiography findings. Cardiac MRI, once the patient is stabilized, yes, a cardiac MRI just does help you in confirming the diagnosis. The books give that an endomyocardial biopsy, and the biopsy should be treated with RT-PCR to prove your diagnosis. However, that is rarely done. Treatment is normally supportive. No antiviral treatment is proven to be effective. Ribavirin has been used, but not with much benefit. Steroids have been tried in the treatment of myocarditis as an immunomodulator, but again, not much benefit. So here is the role of the ICU. So the good level of organ support till the patient recovers. That is what is required in such patients till they recover from the illness. And in this patient, we could manage this patient with IABP and vasopressor supports. However, in more severe cases, patients may require VA ECMO if they don't respond to these measures. Arrhythmias are common in these patients. Up to 50% of the patients have arrhythmias, and antiarrhythmics are used for control of the arrhythmias. Cardiac involvement is associated with a higher mortality, around 26 to 48%. I'll finish my talk. Thank you.